So good evening, everyone. I am Dr. Sanket Nivale, representing Medical Affairs at Emcure Pharmaceuticals. With me, I have Mr. Prashant Agarwal, who is our division head. And today, we all welcome you for this unique platform where we discuss unique cases in acute ischemic stroke. We call it No Thrombosis Workshop Series. With great privilege, I would like to start with the round of introduction. It's my pleasure to introduce Dr. N.R. Ichapuria, sir, who is our course director today. Sir is a director neurology at Sahyadri Hospital, Pune. He is the first who started the neuro ICU and the neuro intensive care at Pune. He has been a pioneer in thrombolysis treatment for stroke in India. More than 300 public lectures and workshops on stroke. Member of the Indian Stroke Association and organizing president at StrokeCon 2012, the organizing president of ISA's Stroke School, ex-president of the Society of Neurosciences, Pune, and ex-president of Maharashtra Academy of Neurology and founder of the Pune Stroke Group. He is the principal investigator for multinational stroke trials like Perform, BG12, Cortical venous thrombosis, Brains Get, Interact 2. Recently, he's been awarded as the health icon by the Times of India Group. Sir, we welcome you for the event. We have the first moderator, Dr. Srikanta Swami, sir. Sir is the head of neurology, Aster RV Hospital, Bangalore. He has worked as a senior neurologist at Apollo Hospital, Fortis Hospital, and Malia Hospital in Bangalore. Professor of Neurology at Vaidehi Medical College, Bangalore, Associate Professor of Neurology at MVJ Medical College, Bangalore. Many national and international publications on his name, organized various CME health awareness camps, and his areas of interest are stroke, epilepsy, headache, and facial pain. Sir, we welcome you for the event.
Thank you.
We have the second moderator today, Dr. Rajshekhar Reddy, sir. Sir is a director, Max Institute of Neurosciences, Max Super Speciality Hospital, Saket, New Delhi. Sir has been a part of Fortis Hospital, which is the Ranbaxy Group company in Noida. 23 publications in national and international journals, participated as a speaker at multiple national and international platforms. Sir, we welcome you for the event today. We have our first speaker, who is Dr. Pawan Kishore Pai. His topic today would be a young case of stroke with LVO. Sir is a consultant neurology and neurointerventions at Wokhad Hospital in Meera Road, has a special interest in management of acute stroke, has performed over 400 cerebral DSAs and neurointervention procedures, Young Investigator Award at World Stroke Congress 2021, only one from India and 5 worldwide awarded with World Stroke Organization Brief Clinical Exchange 2020, has secured prestigious Startup Professional Enhancement Grant 2020, recipient of the Indian Academy of Neurology Traveling Fellowship 2019, winner of the Bombay Neurosciences Association Scholarship 2019, awarded with Victor and Clara Soriano Young Investigator Award at World Stroke Congress, Montreal in October 2018, Most Workaholic Male Doctor Award at Fortis Hospital, Mumbai 2016, has presented papers and posters in various national and international conferences of repute, and is an avid quizzer and a marathon runner. Sir, we welcome you for the event. And the second speaker today would be Dr. Vishal Deshpande, who would be taking us through the case as a unique case of acute ischemic stroke. He is a consultant neurologist at Pune Hospital and Research Center, experience as a sub-investigator for clinical trials in epilepsy and multiple sclerosis. Sir, we welcome you for the event. And now I would like to hand over this podium to our course director, Dr. Ichapuria, sir, for his context setting. Over to you, sir.
Thank you, Dr. Sanket, for the kind invitation and to chair this session. Now, we have a galaxy of very eminent speakers, young speakers, very eminent moderators on this very exciting topic. Now, for me, this acute ischemic stroke has been the turning point of neurology, according to me. And it really started in 1996 or 1995, about 25 years ago, when the whole of neurology was turned upside down by stroke thrombolysis. Before that, I think neurology was a dead science, and I don't know what we studied and what we treated, and there was hardly anything that we could treat. But after this landmark study on acute thrombolysis and stroke, neurology has changed forever and is now growing at a very, very, very fast pace with new drugs, new devices, new methods of treating various patients. So this is a very exciting period to be a neurologist, and especially to be a stroke neurologist, with so much data and so many new things coming up every day. So to discuss all this and to present some exciting cases, we will start the session, and I hand it over now to the moderators.
Sure. So I'll invite Dr. Pawan Pai sir to share his screen and explain or take us through the case. Over to you, Dr. Pai.
We'll have a discussion after every case or at the end?
After every case, sir.
Okay, fine.
Yes. So we can see your screen now.
Yes. Am I audible now?
Now
Yes.
audible, sir.
Okay. So I'll be presenting a case which was very fresh, and patient is still with me. So to set in the context, I'll just tell you that on first and second, I'd gone to Mathura, and third I returned back, and I reached my home at around 8 o'clock. And at 8:30, I just was about to go to my hospital to do my round, and I received a call. We have a young patient, 38-year-old male, and he has an onset of right dense hemiplegia with aphasia at 6:30, and he reached at 8:30 to our hospital. So by the time I reached, the patient was just wheeled to the MRI, and I saw the patient in the gantry. So basically, this patient had a dense right hemiplegia with global aphasia. He was looking around. There was no gaze paresis as such. So NIHS is coming up to 16. And BP was 120/80. Asking about the risk factor, there was a smoking 3 packs of cigarette a day, and he was in a tremendous stress because of family issues in the last 2 years. So which was showing a left MCA, in fact, with a left MCA occlusion, and there were no contraindications of IV TPA as per the history. So this is the MRI diffusion, which shows that there was extensive left MCA-treated infarct. It was a moderate infarct, which was involving the basal ganglia on left side, posterior, like external, posterior part of external capsule, insular cortex, and some part of the parietal cortex also. And this was the ADC mapping, which showed that we had a hyperacute stroke, and which was flare negative, and there was nothing on GRE, which was again, there was no contraindication as such. So basically, we had a situation wherein his left MCA was completely occluded, and ICA was looking good. And we have a situation with a large vessel occlusion and a young patient with an NIHS 16 who has come within a window period. So post MR angio, I spoke with the relatives. So basically, there was his wife, and who was an Indonesian, and a friend of her. So both were like clueless of what's happening. I explained them, this is the state we have, and we need to go ahead with the treatment. So I gave them options of combined IV TNK plus MT versus direct MT. So direct MT, because yes, if the patient is affording, I have taken certain patients with certain criteria in direct MT. In fact, from 26th February to 3rd March, in a span of 6 days, I've done 3 direct MTs with good results. But I gave them an option of IBTNK because of some financial issue, which also takes some time for the clearance. So relatives were taking their time to give consent. They made me speak with several people. In meantime, they were taking some time. Meanwhile, after like from 9:10, when the patient was wheeled back to ER, to 9:30, he was constant. But at 9:30, when I saw him, patient started moving his right leg up to grade 3 power and started obeying commands. So NIHS dropped down to 12. So patient still had motor aphasia with right upper limb weakness. So I told the relatives, look, I feel that the artery must be recanalizing. I don't know, but I feel it is happening. But still we have a patient with such a dense right upper limb weakness and aphasia. So I think we should go ahead with IV TNK, because there are trials which say that 22% chance of artery opening in the large vessel occlusion do exist. I told them the risk of bleed. They agreed, and they gave a high risk consent. We gave bolus of 17 milligram at 9:47 p.m. Patient was in such a state that he could tell that he weighs 84 kgs. Like we drew on the paper, and he was saying, yes, I'm 84. So 85. So that was the weight. So go to needle time was like 78 minutes. And at 10:30 p.m. when I saw the patient again, so he started moving his right upper limb also to grade 3, and had motor aphasia still. NIHS had improved to 6 to 8-ish. So I told the relatives, what we do now is, I feel the artery must have recanalized, but I can't be 100% sure with just the clinical judgment. It is always better that we do a CT angio, because we still have a time for performing mechanical thrombectomy in case the artery hasn't opened. So relatives agreed to this. So patient was wheeled back to CT angio suite, and at 10:50, which was like almost 1 hour from the IV TNK bolus, this is the CT angio, which showed that the MCA was still occluded, and we could see few collaterals coming up, but it was not a situation wherein we could have left the patient with just this much. So I told the relatives, we should do a mechanical thrombectomy now, because now we are in a state wherein we have a patient who is in a window for mechanical thrombectomy, and LVO is still persistent. So there is something called as Lazarus effect, wherein we see that there is a transient improvement and that the patient again worsens. So it's always better that we go ahead with the mechanical thrombectomy. Now, suddenly what happened is that there was a second set of patient relatives who just came in, who were not knowing what was going on. And they were actually the parents and his brothers of the patient. So there was a kind of family feud wherein patient was like, you can say, because of the marriage outside of caste and all, he was not considered as a family member till this stroke happened. And then suddenly all of them came in. And so one set of patient, that is wife and his friend and few friends of the patient, were for thrombectomy, and the relatives who were like mother and brothers were against it. They had a thought that he may bleed, because they had a patient who had bled after mechanical thrombectomy in a window period. So there was a kind of reunion which was not good. So this was a major limiting factor for mechanical thrombectomy. So I found a mediator in between the two who was sensible enough to understand what's going on, because both of them were not coming together for a talk. So I spoke with the mediator at length, which took me some time. But at 12 p.m., patient became drowsy. So patient again had a right upper limb grade 2 bar, which had improved to 4, it just became 2. And lower limb was like 4/5. So I felt patient must not have bled at least, but that Lazarus effect which we saw was a real thing, because the artery had not opened up. So NIHS worsened to 10. Now I told this mediator person, we have to do mechanical thrombectomy, whatever it is, you convince both of them. And we got a clearance by 12:30 a.m., which was like 6 hours from the onset of stroke. I took the patient in the cath lab, and the groin puncture started at 12:45 a.m. So in the cath lab, I was in a dilemma whether to heparinize or not, because, just a few days back, I had thrombolized the patient, booked for mechanical thrombectomy. I had not heparinized the patient, but patient had a bleed because of IV thrombolysis or whatever reason. But then patient had recanalized, but when I did a DSA, that patient had recanalized. Now this patient, I was in a dilemma because of my previous experience whether to heparinize or not. That patient I had not heparinized though. Now, but still I thought, let me give a 3000 bolus of heparin. So I gave. Now what happened after this bolus was that the BP suddenly rose to 190 by 100. Patient condition had not improved. And I asked the anesthetist to have a look at the pupil. Pupil reaction was good. So I took my first shoot of left MCA at 10:50 a.m. So, what do you think must have happened? So basically, I was also, it was a unique experience. The artery had opened up really, and this was a DSA picture. So it showed that there was a good TC3 recanalization. And this was a kind of flow which was, very good considering the kind of LVO which had not opened in 1 hour of the IV thrombolysis. So basically, post recanalization, patient was able to tell his name and count fingers. He was not able to communicate like a full conversation though. There was non-fluent aphasia. Right upper limb power was grade 4/5. Right lower limb power was grade 4/5. NIH was coming up to 4 to 5. I transduced the sheath for BP monitoring because I was skeptical about removal of sheath because of tenectase. So then I shifted the patient to ICU on 4th, that is yesterday. Sheath was removed at 8:30 a.m. and NIH was still the same. 2D echo was normal, Holter attached, young stroke workup was sent. Other basic investigations were sent today morning, like lipid profile. All of them have turned out to be normal. This was a CT which I did yesterday evening at around 6, so that has not shown any bleed as such. So this is a kind of thing which happened just day before yesterday. And to walk you through a few trials which have shown that IV TNK does help in large vessel occlusions. So this is the first trial, 2018. IA TNK, which has showed that 22% of patients treated with TNK had substantially recanalized vessels or had no thrombus as compared with 10% of those treated with TPA. So tenectase resulted in a better 90-day functional outcome than alteplase. And it had a doubling of the rate of arterial recanalization before the commencement of thrombectomy procedure. So I've seen in this, trials may say it is 22%, but in my real time, stroke patients, I've seen it is at least 3 out of 5. The arteries have opened up even before mechanical thrombectomy. So it gives such a good, wonderful result, especially when the patient is not affording. I think IV TNK has really made a life easy for people to, stroke patients to recover. And there is a real-world comparative safety and efficacy data of tenectase versus alteplase in LVO in 2021. So it concluded that AIS patient with LVO treated with 0.25 mg per kg of tenectase had increased likelihood to achieve early neurological improvement compared with AIS patient treated with alteplase. But this association was attenuated after adjustment of potential confounders. And there was no significant difference in 3-month functional or safety outcomes between the two groups. Now, what do guidelines say? So guidelines say that for the early management of patient with AIS, there's a 2019 update to the 2018 guidelines. Which say that it may be reasonable to choose tenectase over IV alteplase in patients with contraindications of IV fibrinolysis who are also eligible to undergo mechanical thrombectomy. And tenectase administered has not been proven superior or non-inferior to alteplase, but might be considered as an alternative to alteplase in patients with minor neurological impairment and no major intracranial occlusion. So basically, this is what I tell my patients who have LVOs. Look, we have two things in hand which can help you, like 22% chance of artery opening with tenectase and up to 83% with mechanical thrombectomy. But it's always better we first give IV tenectase, then go ahead with the mechanical thrombectomy. Now, what are the take-home messages out of this case? First is about the Lazarus effect, which you all know, that there can be transient improvement after thrombolysis. But if there is a large vessel occlusion, the patient may have a worsening of neurodeficits again. And it is always better to demonstrate recanalization after 1 hour of thrombolysis in large vessel occlusion than just going by clinical judgment. And we all know now with the extended trial that tenectase has 22% possibility of complete recanalization. Hence, it is preferable over alteplase. And the last one is that there has to be a judicious use of heparin during neurointervention procedure. So with this, I conclude my talk. I thank Emcure and Bhopal Hospital Management for giving me this opportunity. I thank the chairperson and the moderators for going through the case. Thank you.
Sir, Dr. Srikant, sir, any comments from your end?
Well, I think this was a very good case, and the way he went through the case was excellent. I mean, it was like a textbook description. Only I was just thinking, I mean, do we need, of course, if the facilities are available, we can do that. But most of the time, we don't cross-check of the opening of the vessels after giving IV thrombolysis. We observe the patient clinically, at least routinely, to see if there is any improvement, persistent improvement, and there may be some fluctuation. Unless there is a drastic fluctuation towards the bad side, of course, that is the time when we, in a routine case I'm talking about, not in an institute where every facility is available, we do a CT scan to see the hemorrhagic part of it, if at all, due to thrombolysis. But wherever there is a facility available to see CT angio or MR repeatedly, it can be done. And I don't know whether it is applicable to the large population to do this repeat CT angio to check whether it is recanalized or not. Of course, it has got a lot of advantage. If there is a partial recanalization, patient can definitely get benefit from mechanical thrombectomy. So this advantage, and in larger perspective, probably I personally feel that it may not be possible in every institute where, or in every hospital where they do routine thrombolysis. I think I would invite suggestions or comments from other moderator and the chairperson.
So before we move to Dr. Reddy's comments, sir, I would just like to announce that currently we have 150 more than 150 live attendees listening to our event. Dr. Reddy, sir, your comments, sir.
Right. So I think the case was presented very well. I think that, it took us through nicely the dynamics of the family, etc. And often decision-making is driven by these factors rather than what we'd want to do. And obviously in such a situation, when we're doing that, then it's important to have some things which help us save time. Okay. And the advantage in this era, in the last couple of years that we've seen with all these problems that we've had, you want an agent that you can administer fast, which is efficient. And in this sort of scenario, when you already have so many fluctuations in terms of decision-making, in terms of the family, etc., I think one of the advantages of Tenectase over the other agents that are currently our so-called standard of care is the speed of administration. So I think that's something that is also something that is highlighted in his talk. And I think the rest of it, I think in terms of whatever he did was excellent and was very well shown. So I think that's the comments that I'd like to offer right now.
Thank you, sir. Dr. Ichapuria, sir, your comments, sir. Sir, you're still muted, sir.
Excuse me. Yeah. Can you hear me, Pawan?
Sir,
yes. Why did you have a dilemma whether to do direct MT or give IVT prior to MT? Now, I think it's pretty clear that it's always better to give IV drugs prior to MT. It's pretty clear. So you shouldn't have any dilemma on that. Would you like to say something?
There was no dilemmas on this, sir. It was just an option given.
No, but why do you want to give such an option? Because how will they know that which is better? They wouldn't know that.
That is true. So here the thing is, sir, the infarct size was fair, like it was more than 1/3 of the territory involved, and which was again like it was a large stroke. So basically, that was again.
How much was the aspect score?
Aspects was coming up to 5, sir. Basal ganglia and parietal lobe.
Yeah, I would say aspect was about, MR diffusion overestimates by about 1 point compared to CT scan. But I don't think it's a very large stroke. There is no contraindication to giving IVT. And, now I think standard of care is to give IVT unless the patient comes very early to the mothership. So, this concept of drip and ship and mothership. So if the patient is directly there and directly you can take the patient straight from the MRI or CT straight into the cath lab, then perhaps there may be a role for direct MT. But otherwise, I think IV TPA, IV is not TPA, IV thrombolysis should be the standard of care, and it should be given early. That is now, recently there have been a number of papers, there have been a lot of debates amongst the interventionists whether to not to give IVT or to give direct MT. Final consensus is that you should give IVT, and there is no question of giving that option to the patient because they cannot understand this. And you have to do it very fast. You have to give it within the next few minutes. After they get a consent. Now, many countries you don't need a consent, but in India, okay, we have our peculiar situation, so we need to take a consent. Now, this consent giving is often a problem. I think the next of kin is the person who gives the consent. So if the next of kin is the wife, and if she says yes, that is binding on the rest of the family. It is the next of kin. See, if you ask an extended family, there will always be differences of opinion, and we will waste time. I've had this problem so many times. If 10 people come, 5 will say no and 5 will say yes. So whom to believe? So finally, legally, it is the next of kin who should give the consent, and that should be binding. Legally, it is binding. It is the next of kin who gives the consent. If the next of kin gives consent, then you just go ahead. I mean, legally, you are absolutely safe and there is no problem whatsoever. Secondly, or thirdly, I would say that yes, with large vessel occlusion, we would prefer TNK over alteplase. I think that decision is correct, and we find that it works better. I always give IV thrombolysis even with large vessel occlusion because 20-30% do recanalize with IVT, and you save a lot of money, you save a lot of time, and you save a lot of effort. So definitely IVT should be given prior to MT, at least in our country. I have absolutely no doubt about this. And for large vessel occlusion, yes, we prefer TNK over alteplase. Though there are studies, the studies are weak. There's only one study, that IA extend study. Other studies have not replicated it yet. But okay, that study is there. So the recommendation is 2B. It's not 1. It's not 1, it's 2B. So fine, we are okay with that. I also use it very often. Secondly, I think straight after giving the TNK, the patient should be, now in this case, maybe the situation was different, but we should shift the patient immediately to the cath lab without wasting time. And the groin puncture should be done within 1 hour. Here the times were little delayed. So the results also get little delayed. The results get little poorer as you waste time. It's not that we have 6 hours. We don't have 6 hours. We have to do it as soon as possible. You can do it up to 6 hours, but that doesn't mean you have 6 hours. You have to do it as soon as you possibly can. And therefore, this consent process and discussion with the family should be streamlined, and it should be done very fast. Second, other point I could not understand, why did you have to give heparin?
It's because when we do we put in a sheath, and when we do any neurointerventional procedure, there are chances that there can be clot formation inside the catheter. So that is the reason I gave. And
but is that a standard procedure, or just because I'm not an interventionist, so I am not very familiar with this thing. Does everyone do that, or what is the situation?
It is
for my knowledge is inadequate in this field.
Dr. Ichapuri, I think recently, I think a year back, there was some article discussing about giving heparin during the procedure or antiplatelets prior to the procedure if they have been already on. And there seems to be increased intracranial bleed, not necessarily due to intervention because of the anticoagulants itself. But still, it is not very clear. Few people have used it, interventionist, but final verdict is that it should be avoided as far as possible.
Yes, I think so, because you see, when we give IV thrombolysis, the recommendation is not to give platelets or heparin for 24 hours. So I'm not very clear, if you do the intervention, do you really need to give the heparin? I am not very clear on that point. Is that a guideline, Pawan? What exactly is that situation?
There's no guideline. It has to be done case-to-case basis. And second thing is, like, what I have noticed in few cases is that when we don't give heparin, even when the artery opens up, suppose if there is like a stenosis, like say 80%, 90% stenosis, which we don't know when we start the procedure, the artery tends to get blocked as soon as it opens. So
that means, is it ICAD? Is it an ICAD or it is a thromboembolic phenomena?
In this patient, we see when we go ahead and do any procedure, we don't know what is the outcome. Like, it's a blind procedure. When we do a thrombectomy, only after opening up, whenever there is a flow across, we come to know whether there is a pre-existing stenosis. Now, when we don't heparinize, what we often notice is that there is the that recanalization just doesn't stay. It gets reoccluded. And there are also access site complications which do occur when there is no heparinization. So, yeah, and even the catheter clot formation, all that thing can happen. There is a possibility.
Yes, Dr. Birud wants to answer this question. Dr. Birud, can you answer this question?
Yes, sir. Sir, this is standard of care. If you are going for a therapeutic intervention, you have to give 5,000 international units of heparin. You are going to put a 8 French sheet in right groin. Immediately, if you know that you are going for a therapeutic procedure, you have to give 5,000 international heparin. This is absolute guideline from the neurointerventionist. A therapeutic procedure, you have to give heparin because your procedure is going to take 60 minutes, at least 60 minutes. It is okay if you find that the vessel is recanalized. By that time, your patient is.
So you give it in the beginning, or you do the angio and then give it?
Oh, in the beginning only.
But you don't know whether the vessel has opened or not, no?
Sir, it doesn't matter. It doesn't matter in this situation. If your vessel is open, the 5,000 international heparin will not cause any bleeding chances. If at all, we are more cautious about bleeding, you can give 2,500 international units to 3,000 international units of heparin to take a check shoot. If your vessel is open, you are done. You are not going to do a therapeutic procedure. If the vessel is occluded, you have to give additional 2,000 or 2,500 units of heparin additionally, because on an average, the rate of recanalization or contemplating a therapeutic procedure, you have to keep all the system heparinized. Until unless you keep all the system heparinized, you will increase the chances of complication, either a thrombus formation inside the sheath, or that thrombus may migrate into systemic circulation, will cause another problem. So, a therapeutic procedure, 5,000 international heparin at the starting of the procedure. If in doubt, at least start 2,500 units, take a check shoot. If your vessel is open, just leave that sheet for next 4 to 6 hours. And after 6 hours, you can safely remove the sheath also.
Okay. Okay, I didn't know this point. So thank you for the clarification.
Thank you, sir. Thank you.
Any other point?
I'll take a one second with Mr. Dr. Pai. Now, what are the chances of reperfusion injury when you open up the large vessel? Because some of the interventionists are worried about that part of it. And if the patient is stable, they hesitate to open up, fearing that there can be reperfusion injury and worsening of the stroke. What is your comment about that?
Sir, on this front, I would like to say, if there are good collaterals, the chances of reperfusion injury are very less. In fact, in this patient on the CT angio, if you notice, he had already developed a good collateral, which was also causing improvement in his clinical status. So in such situations, the chances of reperfusion are very less. And if there is no cross flow, if the parent artery is the only source, and if the patient has not already developed any collaterals by the time we do the procedure, then yes, the chances of reperfusion injury are high. But that is case to case basis. Now, what we have to do at that moment is very important. We have a young patient, 38-year-old. I'm not saying go by emotions. Now, suppose if we say we don't do anything, and if the patient, the artery doesn't open up as such, then as per the, like again at 12 o'clock, what I was, I was clinically monitoring the patient throughout. There was worsening. So if we had not opened, maybe he wouldn't have recovered. So we have a situation wherein we have to act at that moment. It is that moment where we have to take decisions, wherein after that 6 hours, we can't do anything. So we have to explain, I explained the relatives that there is a risk of reperfusion injury, but we have to go ahead.
That's correct.
I don't think we should worry about reperfusion injury, Dr. Swami, because the risk of symptomatic ICH is very low.
That's true.
It is within acceptable limits. It is within, say, 2 to 3 to 4%. So I wouldn't worry too much. It is important to reperfuse. Don't worry about the injury. It is important to get PK free.
I just wanted to emphasize in a patient, this is a different patient in a situation where we have a large infarct wherein there is a large vessel occlusion. In that situation, probably the reperfusion injury chances may be more. And
yes.
Yeah.
So it depends on the size of the infarct.
Yeah, exactly.
See, the thing is, if you don't reperfuse, anyway, he's going to do badly.
Yeah, that is true.
If the aspect score is low, anyway, and the infarct is big, anyway, he's going to do badly. So if in time you can reopen, the one of the risk factors for reperfusion injury or in ICH is large infarct. So if the infarct is small, the chances are less. If the infarct is big, chances are more. And the more time you waste, the chances are more.
Yeah, that's true.
Yeah. So,
So I think
yeah,
it was a great discussion after the first case, and the participants are also now have increased from 150 to 191 and more. So with that, we move towards the next
any
case.
questions from the participants?
So there is nothing in the chat box so far. We have kept the comment.
No. So I'll try to pull it from the question from audience link that side. We can continue with second case, and I'll try to pull it from that side.
Yes,
Yeah.
because we want a heated discussion.
Yes, sir. Looking forward for it, sir. Now I'll invite our second speaker, Dr. Vishal Deshpande, sir, for presenting his case. Over to you, Dr. Deshpande, sir.
Am I audible?
Yes, sir.
Just a minute. Good evening, everybody. I'm Dr. Vishal Deshpande. I'm consulting neurologist working in Pune in Dinanath Mangeshkar Hospital as well as Pune Hospital. Today I'll be sharing 2 or 3 cases of large vessel occlusion. Did successful thrombolysis by Tenectase, and one cardiomyopathic stroke did successful thrombolysis by Tenectase. So I'll be sharing my screen. can see my screen now, right?
Yes, sir.
My screen, yeah. So this is the case one. This is a 60-year-old lady. She was having diabetes, hypertension, and hypothyroid. She had onset of symptoms at around 11:30 a.m. She noticed right-sided paresthesia, weakness, and she was unable to coordinate, unable to walk and speak properly. She reached the emergency department at around 12:30. And on examination, she was alert. She was understanding. The understanding was poor with partial Wernicke's aphasia. The fluency was impaired. There was word finding difficulty. There was right facial weakness, and the power was grade 1 and grade 0 in upper and lower limb. So the NIHS was 14, around 14. This was her MRI, which was done immediately. So here you can see that she was having patchy infarcts in the left MC area. Here is the diffusion images, the enlarged diffusion images here, and on ADC you can see the angio was performed.
Dr. Vishal? I'll just connect with them offline. He just confirmed he will reconnect in another second.
I just suggest you ask him to keep his video off. Okay, so his video.
Probably the video bandwidth would be better. Yeah,
Definitely.
great. We'll do that.
Yeah.
There is only one question was there, sir, which was on counseling part. The question read as, is there any specific suggestions to reduce dilemma in counseling?
Okay, the dilemma in counseling was, this was a very peculiar situation. Otherwise, we usually don't have such situations wherein there are no two schools of thought, like the family takes decision in unison. Here they were actually fighting against each other, telling about all those 2 years of bad experience, all that. Now, after meeting, it was that kind of a situation where it was not pro or against thrombolysis, but it was about reunion, which was not a fruitful one. So basically, that sensible mediator was the one who I was communicating with. Otherwise, if I had met both relatives together, it was creating a fight. And I had said that wife is the only one who's going to decide on this at the end of the day. So all these things were there. Financial issues were there. So, and the consent took time because of financial clearance. Otherwise, it could have been done earlier. Thank you.
Vishal, sir, you're still muted. Yeah.
I'm so sorry.
So you can keep your video off if there is a low bandwidth of the internet. That would help you in fluency of your speech, sir. And sir, if you want, I can present your slides as you have already shared it with me. Would that help, sir?
The slides are seen or not?
They were seen, sir. I think you can initiate that, and if again there is a problem, then I would present it from my end. Sure.
So
We can see your slide, sir. Go ahead.
yeah. So we did thrombolysis and the CT angio. After that was showing that the right MCA was showing a good flow. So this was the case where we so though the flow is little bit low, but here we can see that the flow is good. So there was a good improvement of the patient, and we can see here that there is a clinical recovery also. The power on the right side is really improved, and she is understanding also. So at the same time, right. So when she came, she was not able to move, and after thrombolysis, she improved remarkably, and she was able to understand, and she was able to speak as well. Hello.
Yes, sir. We can hear you, sir.
Yep. So okay, she was investigated. The echo was normal, and this is the first case. So any inputs from the chairpersons and moderator?
As of now, it is a straightforward case which has responded to IV thrombolysis.
Yes,
of course, if there are any abnormal investigations pointing out to some rarer causes of stroke, of course, that needs to be handled. But otherwise, IV thrombolysis effect is seen very clearly within improvement in the next 2 days.
Yes, sir.
Excellent improvement. Well done.
Thank you, sir. So, so pretty straightforward case, and the second case is also pretty straightforward. So here is a 50-year-old male, diabetes, hypertension, admitted with left hemiparesis. The symptom of onset was around 10:30 p.m. He arrived in here around 11:15 p.m. He was drowsy. There was dysarthria. There was left-sided facial weakness, and the gaze was to the right side. The power on the left side was 2/5. The NHS was around 12. So here is the ADC as well as the perfusion scan. Here we can see that the ADC core is around 61, and the mismatch is around the mismatch is more. So so we did the MR angio, and it was showing complete cutoff of the right MCA. The patient was taken for IV lysis with TNK, and here is the same. The patient improved remarkably with post lysis NHS, or at the time of discharge, the NHS was around 7, and the workup didn't show anything significant. This was the MRI at the time of discharge. He had just this much area of infarct which was involved. And the MR angio also improved remarkably with just IV lysis, no MT required.
It was M1 segment occlusion, is that right?
Yes, sir.
Yeah, because we don't see usually M1 segment occlusion so nicely opening up with lysis. But anyway, this case is a very good response for IV lysis. That is correct.
So these both two cases were I wanted to show it here. The large vessel occlusion, they responded to IV lysis very well, and the workup was not really significant, very straightforward cases. So now I will move to the third case. 74-year-old male. He has a post-CABG status. He was having diabetes and hypertension. He was on antiplatelet and statins, and he was admitted with right hemiparesis and aphasia. He noticed it when he woke up at around 2 a.m. So wake up stroke. At 2 a.m. he noticed that he was not able to move right side, and he was aphasic. When he arrived in ER, the BP was around 200 by 120. He was aphasic. The right-sided power was around upper limb 2 and lower limb 3 by 5. The NHS was 15, and this was the MRI. He was straightway taken to the MRI, and this was the MRI. Here we can see just fairly there is a diffusion weighted brightness. He was just having a developing kind of infarct. This is the flare. There was a flare diffusion mismatch. This was the angio. So the angio was normal on the left side. The right side IC was not seen. The left sided MC, the right MC was filling through the left side. So what is the next step? What should we do? As this was the neck angio. Here we can see the left ICA is seen properly. The right ICA is not seen properly. So this was the ADC image. So he was lysed with TNK and he improved post lysis. The understanding was good. He had only motor aphasia, which was gradually recovered, and the power also came to 4/5. So he had global aphasia, which improved. So he had partial motor aphasia, and that also gradually improved over next few days. And this was the MRI post lysis. There were just minimal hemorrhagic changes. There GRE blooming on the left side, and the diffusion weighted shows slight changes which were not seen earlierly. So though there is a increase in the infarct on the diffusion weighted images, as well as there is a blooming, but the clinical recovery was really good. So this is the case. Probably the cause in this case was cardioembolic. The 2D had shown depressed LV function, and there was a scar also. So, but the clinical recovery was good.
Do you have the angio post TNK?
No, sir. Post TNK angio is not available, but the angio was fairly same. The right IC was not filling.
No, but we want to see whether that opened up.
No, probably that was a chronic occlusion.
No, we don't know that.
Yes.
So one of the things,
I mean, we are assuming, we don't know that.
Yep.
Now this brings us to a question now, as we discussed in the previous case, when we see a large vessel occlusion, like in these last two cases where the large M1 segment is supposed to be large vessel occlusion and it has opened up for lysis. Now, do we jump into mechanical without waiting, or should we wait? That is a question.
We should not wait.
And now in these two cases, it has opened up according to the MRI.
Yeah, but see, we should not, the thing is we should not wait. The principle is we should not wait. Okay, you may do an angio, you may do a DSA, and you see that the vessel is open, that's okay. But waiting is totally no. In this patient, they improved very rapidly, so maybe we got away with it. But the basic principle is that after you give IV thrombolysis, you should take, if possible, immediately to the cath lab without waiting.
The second thing we should keep in mind is also that the mechanical thrombectomy, we are aware that it's an invasive procedure. And in these two cases, whether that would have had some complications, without that, she has saved that complications. These are some unanswered questions in these two patients.
No, he has saved the patient. I think they are fantastic. I mean, the demonstration that IV thrombolysis can open up large vessel occlusions has been shown most beautifully in all the cases. Most beautifully, even Dr. Pawan Pai's first case. So therefore, I very strongly feel that you should give IV thrombolysis in every patient unless there is a contraindication. Because as you have seen, we have saved the patient from MT, which costs lakhs of rupees. So I think it's a beautiful demonstration of large vessels opening up with TNK. It's very creditable, and I'm really very happy to see all these cases.
After how many days?
In both cases, Vishal, Swami, just 1 second. I just want to ask Dr. Vishal, why are we choosing MR imaging as the modality of choice in such a situation. I think that there's no question of waiting after you give IV thrombolysis. You'd like to take up the patient for a DSA straight away if they have, and you wouldn't want to wait. I completely agree with
both cases. So in first cases where we did CT angio, immediately after thrombolysis, we can see the vessel is opening up, and in the second case where was a diffusion perfusion mismatch, we also did immediate MR angio, and there the vessel was opening. That's why we didn't really went ahead with DSA.
So I wanted to ask you.
In both cases the hospitals were different, so the protocol is a little bit different.
Okay. So my concern is twofold. One is that I'm not sure about the time again, either because there are 3 cases. I wasn't sure. So I thought you looked for a perfusion-diffusion mismatch because they were out of window, or what exactly happened? I'm not sure. I didn't get that part of it.
No, so we have a protocol here in the Dinath Mangeshkar Hospital. So they usually do a diffusion-perfusion mismatch before thrombolysis. So it's not that is, I mean, we can really do only CT and we can go ahead with thrombolysis, but they have a protocol.
They do a CT.
No, but you don't need that protocol, Vishal. If the patient has come within 4.5 hours, you don't need to do diffusion-perfusion mismatch.
I agree.
You don't need it. See, you're wasting time.
I agree.
You don't need.
Only CT scan is sufficient. And
yes, CT scan does not show hemorrhage. Patient has hemiplegia. Don't waste time, because doing all these things takes about half an hour or 15-20 minutes. I don't know how long it takes.
15 minutes it takes.
Yeah. But why do you want to waste that much time? I mean, okay, if the patient is outside the window, he's come at 6 hours, 8 hours, 9 hours, 10 hours, then maybe you need advanced imaging. Yes. But if the patient has come within the early time window, you don't need advanced imaging.
Agree, sir.
This is the standard protocol all over the world. Now, if you have a local protocol, I don't know, but this is the standard protocol all over the world.
Agree.
And even the MR imaging per se, right at the time of initial this thing, unless you have really very fast protocols which are doing this very limited MR imaging, I think that may also not be really of great value. You want to do a CT, you want to do a CT angio. If you're seeing any kind of, and you're worrying about contrast with CT and all that, that's not really a concern in an acute stroke situation. So then you go ahead and give IV thrombolysis, and then if there is a large vessel occlusion, take them to the lab immediately. And like Dr. Chapriya very correctly said, out there you go and find out that the vessels have opened up there, that's fine. No problem. There's nothing wrong with that. Even after you've done a DSA and proven that the vessels are open, it's perfectly all right. You should not be waiting. I think that's the standard of care today. So the other thing is regarding the counseling of the family. I think one of the things that we need to emphasize here is that the way I see it, I tell them that, look, this is the standard of care. This is the thing that is done in the best centers in the world. There's a risk. You show them that images of the number of patients who benefit, number of patients who are unchanged, and the small number of patients who may worsen as a result of your IV thrombolysis. And subsequently, I think one of the things that I think Mayank Goyal used to say is that, you tell them that this is what I will do if it was my mother or father. So I think that is, I know it's an emotional play and it's not a fair thing to do, but sometimes they're doing the counseling on the way to the DSA lab. That's what they're doing in good centers in the West. So, I mean, just to add a few points here.
Yeah, so, Vishal, this thing of doing CT angio after giving TNK, I don't think we should do that,
Yeah.
We should take the patient to the cath lab. If you think it's an LVO, the DSA shows that there's full recanalization. Great, come out. You don't have to do anything, but don't, you're wasting a lot of time. Suppose the vessel had not opened. Then again, CT angio, you wasted another 10-15 minutes. Again, you transport the patient. Ideally, it doesn't make sense.
Yes. Ideally, it should be CT, IV thrombolysis, and then DSA.
CT, angio.
See, if it is a large vessel occlusion. Yes. Sorry, Rajshekhar, continue.
I'm sorry. I'm going to just interrupt there. It's CT head at the same time as CT angio neck and vein vessel. Right at that point, and you can start IV thrombolysis in the CT machine if required. I mean, if you really want to do that. But I'm saying you do a CT head as well as CT angio neck and vein vessel for everybody who comes in within the window.
Exactly. No. You should do it in the CT scan only. And then if you find an LVO, transport him to the cath lab.
Exactly.
Or if it is a place where you don't have a cath lab, then you do this drip and ship. But do it fast. And drip and ship is definitely inferior to mothership.
Yes, for sure. Ideally, that should be.
Sir, our audience has been active, and I have a few questions here from the audience. If with your permission, sir.
Yes, of course. Come on, we want that.
So the first question comes in as, what is better, CT-based protocol or MRI-based protocol?
Definitely CT-based.
Rajshekhar will answer that.
Yeah, so I think that, in terms of, there are now some centers which are starting to use MRIs because there are fast sequences, you're getting it quickly. They're doing limited sequences in an acute stroke setting, so-called MR fast protocols. But the standard of care, to my mind, still remains CT head, plain, with a CT angio neck and brain vessel. Look out for the aspect score. If you're seeing a large vessel occlusion, you will still, like Dr. Ichupuria said, irrespective of whether it's a large vessel or whatever, if there's an indication to give IV thrombolysis, you will give IV thrombolysis immediately. And if there is a large vessel occlusion, which merits immediate shifting to the DSA lab, then you must take to the DSA lab and do this. And if you prove in the DSA lab that the vessels are open, that's fine. Not a problem. If there isn't, then you go ahead with the mechanical thrombectomy along with this. And that's, I think, till now, the standard. Any further advanced imaging modalities should be done only for people who are out of the conventional window. And, people have talked, I have asked stroke experts in the world about, whether diffusion changes actually change after you do an intervention where you recanalize the vessel. And they say they don't know, because they never do an MR diffusion at that point. They've always done CT. So they don't know truly whether diffusion changes come. So I will actually change in the future. So, there are good places where only a CT head, CT angio, neck and brain vessel, and then the interventions that follow, like I've listed, should be done. That's my standard of care. All the other advanced imaging modalities, for the ones which are iffy, we are not sure and we need some help. That's what I think should be done.
Thank you, sir.
Yes, Rajshekhar, I'd like to comment on that.
Sir.
Rajshekhar, I think what you said is absolutely correct. Time is of the essence, and the problem with MR is metal and movement. So many times, we say that there are fast sequences and you can do it in 10 minutes and 15 minutes, but there is this metal and movement issue. And and all over the world, it has been found that when you do CT angio, your thrombolysis rate and your door to needle time is on an average much better. And because your door to needle time is better, your results are better. And therefore you can take more patients for thrombolysis than if you were to do MRI. Unfortunately, I find that in India, most people are doing MRIs. I don't know why this has come, but most people, they want to see a diffusion lesion. But you don't need to see a diffusion lesion before you thrombolyze. You don't need to see it. Why should you see it? There is a clinical radiological mismatch. That's all you need. You need to rule out a hemorrhage. That's it. And the person has a stroke. Why do you want to see a diffusion lesion? You don't need it. You may need it in advanced cases, difficult cases. Okay, that time perhaps you can do it. But for the routine 4.5 hour cases, there is no need.
No, I just beg to differ, sir. Just suppose if there is a chronic total occlusion, just doing CT angio may not suffice. We have to do a CT perfusion as well. This is the intervention is
in what time window?
Like in the situation where, like, if the patient is to be taken for a large vessel occlusion mechanical thrombectomy, like in the third case, wherein the right ICA was presumed to be chronic total occlusion. So basically, if there is a chronic total occlusion,
how are we saying it is chronic? I mean, on what basis are you saying it's chronic?
No,
I mean, where is the evidence to say that it is chronic?
There is no evidence to say it is chronic. But
then how can you say that?
Now, suppose if we have a situation, sir, I'll just give you a hypothetical situation wherein there is a Todd's palsy and we find a CTO.
You find a
chronic total occlusion and we just do a CT angio without perfusion and we take up the patient for thrombectomy. So, or IV thrombolysis.
I mean, that is a very rare, I've never encountered that situation. Yeah, sorry. Todd's paralysis, and now I don't know. I don't know. I've never encountered this. This is a very rare thing. Pawan.
Yeah, it's a rare thing.
I mean, why do we have to talk of? We are talking of standard things, day-to-day practice. I mean, this type of scenario, I don't know how many of us will encounter.
And
if we encounter, fine, we will think about it at that time.
I'd like to just ask Pawan about that. That's an thing when we're talking about a Todd's paralysis also, any such thing, we have enough evidence to say that if you thrombolize stroke mimics, you don't need to worry. All right. I mean, by and large, throat mimics, even if you thrombolize, there's good data to show that nothing will happen. The second thing is that you have a situation where you're saying that there's a Todd's paralysis and then you're seeing a chronic total occlusion. So you're concerned that you will take them up for a mechanical intervention. You'll do a DSA, and I presume that you are the interventionist who will tell us that this is a chronic occlusion. So you will not do any intervention after that. Why would that be a reason to worry? I'm saying that your perfusion image, assuming that it's interpreted properly, will tell you that the Todd's paralysis, there is no area that is salvageable, and you will not take that patient up further for a mechanical intervention. But even if you have a chronic total occlusion and you do the DSA, you will see that there's a chronic total occlusion and you will not do any intervention. So you will just do a DSA. How does that matter? So you have a Todd's paralysis, you thrombolized it. That's fine. That's perfectly acceptable. In many places they would do it, and okay, it happens. Uske baad you'll do a DSA and then you will say there's an inclusion. You will not do any further. So I can't see a perfusion imaging helping that. The perfusion image is only when you're in a particular place where you think that you're out of a conventional window, or I'm saying that you are learning as you go along. If your CT machine guys are saying that, look, every patient who comes in, there's a DNB student who's doing a thesis and he's doing a CT perfusion within 5 minutes of doing that CT angio, just to see what your data looks like and your center learns how to interpret, that's fine. I mean, you're using the 3 or 4 minutes or 5 minutes, that's okay. But beyond that, I do not see this particular example that you gave being of any value. Okay.
Agreed, Rajshekar, agreed.
Sir, I think it has been an intense discussion, and our time slot, which we have promised, was 1 hour, which has crossed by 8 minutes now. I would request, sir, you as a chairperson to summarize, and then we'll take it with the moderators and close the event, sir. Over to you, sir.
No, we can discuss till the cows come home, which is at 12 o'clock. And, this discussion can go on and on and on and on. But I am very happy to see these very beautiful cases. And it re-emphasizes the point which we already made, that, IV thrombolysis works. It works wonders. It's a wonder drug, according to me. And here it has been shown that even in LVO, it's working. People say, okay, 20% it opens, 30% it opens, M1 opens 30%, M2 opens 40%, but it does work. So, and it's cheap. I mean, so why not give it? And definitely, I think, according to me, it's a standard of care to give IV thrombolysis before doing any intervention, unless it's a very, very special situation and there is a contraindication, like some, anticoagulant is in the system or something like that. But otherwise, such beautiful cases have been shown with IV thrombolysis. I must congratulate both the speakers for an excellent job. And, these young guns are doing such a wonderful job now. A little bit of fine tuning maybe is required here and there. But the important thing is that so many patients are benefited by this maneuver and by these young guns. So congratulations to both the speakers, and congratulations also for making Tenectase available to us at a sensible price. Thank you.
Thank you, sir. Move to Dr. Rajshekhar Reddy, sir, for his comments, sir.
Thank you. I think Dr. Chipuri has summarized that very well. I think it was excellent presentations from both the speakers. I must congratulate them. And sometimes it's a very good thing to show clear-cut, nice cases which have, people have improved. And also there's always something that we can debate and learn from every case. So they also brought that out very nicely. And I don't think anything further than that I need to add today. I think, this has been very nice experience. And I think as we go along, we'll learn more and more. Thank you so much for this, Sanket. Thank you.
Thank you, sir. Dr. Swami, sir.
I think we learned a lot by these two cases, and we differed in so many aspects. That shows that there is still a lot of areas which needs to be explored in the stroke therapy. That I think all of us should agree. And we keep on learning with all these typical simple cases as well as complicated cases. And both the case presented really well, and they gave us a lot of time to debate on these things. And thank you, Emcure, for giving this opportunity to take part in this. Thank you very much for that.
Thank you, sir. Dr. Pawan Pai, your comments, sir.
Yeah, so basically, Tenectase has really helped interventionists like me leverage, to give IV thrombolysis prior to thrombectomy in the situations wherein, I badly want to do thrombectomy, but patient is not affording. So Tenectase helped me in a lot of such situations. So I'm very grateful to you.
Thank you, sir. Dr. Vishal Deshpande, sir.
Yes, sir.
So your comments, sir, before we close.
No, I mean, from Ichapure sir as well as Rajshekhar sir and Swami sir, I learned a lot, as well as Pawan sir's case was excellent. So as a protocol, we should fix that CT angio, then IV thrombolysis, and then DSA and MT. That should be very clear.
Thank you, sir. Great, sir. I would just like to announce that we have now reached a total attendance of more than 200. To be specific, I've got the figure of 217 live audiences listening to us today, sir. And I think this is the first of its kind that we have started. And I think the journey is long. And again, we would meet with another 2 cases in the next month, and we'll have a handsome discussion with active audience interaction, just the way Dr. Ichapuri has mentioned. And we will make it more, available to more audience in such a way that everyone and most of the patients would get the benefit of treatment and less disabilities to the world. With that note, I would like to end this meeting today, and I thank each and everyone participating and presenting today. It had been an excellent discussion, and I think everyone has learned something today from this discussion. So with that, thank you each and every one of you, sir. Thank you.
Thank you. Good night, everyone. Thank you, sir.
Good night. Good night. Bye.
Thank you.
Prashant.